Вторая автоматически, да?
Не,
Хорошо, спасибо. Так. Мгм. Good day. Our lectures today is liver cancer and pancreatic cancer. The first lecture is liver cancer. Anatomy of the liver. 3 lobes, right lobe, left lobe, and middle lobe. The blood supplying of the liver is from common hepatic artery, and then she divides to 2 arteries, right and left hepatic arteries. And the same vena porta, which divided to 2 left and right vessels of vena porta, and common bile duct arising from left and right bile ducts, or in other word is خليدة. As we see here, hepatic vein, left lobe, right lobe, and small bile ducts, and hepatic ducts, left and right, and the end of left and right hepatic ducts, common bile ducts. Gallbladder. The blood supplying, as we just now we told, vena porta was divided to 2 veins, right and left part, common hepatic artery, and this is vena cava inferior. Carcinoma of the liver. There are 2 classification of carcinoma of liver. The first is primary liver cancer, and next is secondary liver cancer. Secondary liver cancer, it means metastasis in liver from other organs. Primary liver cancer is divided to 2 groups. The first is cholangiocellular carcinoma, and the second is hepatocellular carcinoma. Hepatocellular carcinoma arising from hepatocyte of the liver. Here we see it is metastasis in liver. It is multiple metastasis in liver right lobe. 90% of primary liver cancer is hepatocellular carcinoma. It is the most common liver cancer is hepatocellular carcinoma. Epidemiology. Primary liver cancer. Primary liver cancer take the sixth place in the structure of oncological morbidity among all other cases of cancer. 5.7% from all cases of cancer. We told here about primary liver cancer. We don't talk about secondary. Secondary, it means metastasis from other organs. But now we just discuss primary liver cancer. No, sixth place in all the world. The ratio of cases to the death is 0.95. In the USA, 0.87. The highest morbidity and mortality observed in Africa and Southeast Asia. China accounts for 55% of all cases. Etiology. Viral factors. Epidemiological studies have found a mirror match areas endemic for hepatitis B and hepatocellular carcinoma. In Southeast Asia and East Africa, carry the virus are up to 20% of the population. And in this case, this area is multiple patients with hepatocellular carcinoma from the hepatitis B. Risk factors, hepatocellular carcinoma. Chronic viral hepatitis infection, HBV infection, HDC infection, and HCV infection. Second risk factors is congenital liver disease, hereditary hemochromatosis, deficiency of alpha 1 antitrypsin, tyrosinemia. Tyrosinemia, the most common cases in Middle East countries. Environmental factors. Oral contraceptives, steroid hormones, smoking, aflatoxin. Cirrhosis. And the last risk factors is obesity and diabetes. Form of growth of hepatocellular carcinoma. Expensive growth, encapsulated tumor growth, compressing the surrounding liver parenchyma, nodular or pseudonodular form, multifocal form in many segments of the liver. As you remember, there are two lobes and the liver had 8 segments in anatomy. Combined, including the elements and expensive and nodular growth. Fibrolaminar growth registered in young women. Combination of hepatocellular carcinoma and cholangiocellular carcinoma commonly observed in cirrhotic liver intact, more common in men. About now TNM classification of the liver cancer. T1 is solitary node 2 centimeter or less in the greatest diameter without vascular invasion. T2 solitary node 2 centimeter or less in the greatest diameter with vascular invasion or multiple tumors which are located in one lobe less than 2 centimeter without vascular invasion or one solitary node more than 2 centimeter in diameter without vascular invasion. T3 solitary node more than 2 centimeter in greatest diameter with vascular invasion or multiple tumors which are located in one lobe less than 2 centimeter with vascular invasion or multiple tumors in one lobe more than 2 centimeter in diameter with vascular invasion and without it. And T4 multiple tumors in more than one lobe or tumors involving the portal or hepatic vein, or tumor without direct invasion to adjacent organs, or tumors involving the visceral peritoneum. Lymph node status. In one lymph node metastasis, it means metastasis in regional lymph nodes, which including hepatoduodenal ligament, and distant metastasis M1 if there are metastases in other organs. And staging depending on TNM classification. Stage 2, 1, 2, and 3, and stage 4 divided to two groups, stage 4A and stage 4B. And here, as we understand, depending on the stages, on the staging, we can talk about morbidity, prognosis, I mean. No, T1, what mean T1 and 0, 0, T2 and 0, 0, and 3 include T1 and 1 and 0, or T2 and 1 and 0, or T3 and 0 and 0, and stage 4A, T4 and 0 and 0, stage 4B, any T, N1 and M1. Cholangiocellular carcinoma. Cholangiocellular carcinoma is malignant tumor which grows from the epithelium of the bile ducts. Synonymous with this concept are cholangiocarcinoma carcinoma. Cholangiocellular carcinoma, a relatively rare disease occurring with a frequency of less than 2% of all malignancies. The detection rate of cholangiocarcinoma is 1 to 2 people per 100,000 population. It is much higher in the countries of Southeast Asia due to endemic chronic parasitic processes of the liver. Cholangiocellular cancer is divided into intra and extrahepatic cancers. Intrahepatic lesions is found in 10 to 25% of cases. According to the form of growth, cholangiocellular carcinoma is divided into 4 types: infiltrative type, polypoid type, exophytic type, and mixed type. In 90 to 95%, cholangiocellular carcinoma represents adenocarcinomas, minorly highly differentiated adenocarcinoma. This highly differentiated, this degree of carcinoma, if you remember, we discussed this type of investigation, highly differentiated, undifferentiated, and middle differentiated. Risk factors: primary sclerosing cholangitis, cholelithiasis and hepatolithiasis, pyelodigestive anastomosis, non-specific ulcerative colitis, adenomas of multiple papillomatosis, congenital cysts of the common bile duct, Carlisle disease, Crohn's disease, contact with radioactive thorium dioxide, parasitic invasion of clonorexicensis, and Obstetricus viverrini, smoking, hepatitis C, HIV infection, liver cirrhosis, diabetes mellitus. Diagnostics of liver cancer. Examination of patient. Physical examination. Laboratory testing. Cancer antigen 19-9. CAA. Cancer empiric antigen, and AFP, alpha fetoprotein cancer antigen. ECG and FDG, CT scan of the liver in the arterial veins, the retroperitoneal space. Consultations, cancer surgeon, physician, chemotherapist, and radiologist. HPS virus, RV virus, and HIV virus group, and risk factor blood and group ultrasound of liver, chest radiography, endoscopy, and fine needle aspiration biopsy or curettage biopsy of the tumor under control of ultrasound. The main clinical manifestation of cholangiocarcinoma is obstructive jaundice. Caused by obstruction of the bile ducts. A characteristic feature of this syndrome is the dependence of the manifestations on the localization of the tumor processes. If the tumor is located higher in bile ducts, the date of its manifestation later, and tumor is bigger. No patient with jaundice. Severe pain is not typical manifestation for cholangiocarcinoma cancer. However, when secondary infection joined and the tumor located in the distal hepatic cholelithias, acute cholangitis may develop. It is characterized by chills, fever, pain in the right hypochondrium. Advanced forms of the disease show signs of cancer intoxication as pain, fatigue, malaise, and weight loss. Courvoisier's symptom appears in case of distal lesions with intact cystic duct. Laboratory diagnosis of cholangiocellular carcinoma. Increased AST, gamma glutamyl, hyperbilirubinemia through the jaundice, mainly due to the direct fraction. If the patient had hyperbilirubinemia due to the direct fraction, it means mechanical jaundice. Remember, it's not infection jaundice, it's hepatitis. Here is, we can talk about mechanical jaundice. Increase in the level alkaline phosphatase, prolonged obstruction of the common bile duct may lead to deficiency of fat-soluble vitamins, anticoagulation, hypo and dysproteinemia. Extended the intrahepatic ducts. DCM, extended intrahepatic ducts. Tumor invades in surrounding organs frequently. More often, it is hepatic artery or pancreas. The most important method of diagnosis of cholangiocarcinoma and their resectability are direct methods of staining of the bile ducts. Endoscopic retrograde cholangiopancreatography, percutaneous transhepatic cholangiography, and cholecystectomy cholangiography. And here we see the tumor of right hepatic ducts. Tumor common bile duct. Fistula cholangiography. CT scan of infiltrative intrahepatic cholangiocarcinoma. Multifocal lesions of liver. DCM, multifocal lesions of the liver. Metastatic lesions. Hepatocellular carcinoma. salangiocellular carcinoma treatment of carcinoma of liver divided to three types of treatment: surgical excision, radiotherapy, and chemotherapy. What we can tell? The zero stage is it mean or the first stage T in situ in 0 in 0 and the first stage T1 in 0 in 0. Here in this stage our treatment is surgical, just surgical without additional treatment like chemotherapy or radiotherapy. Stage 2, T2 in 0 in 0, this same is surgical treatment. The stage 3 and 4A is surgical, adjuvant chemotherapy after surgical chemotherapy, and radiotherapy. In stage 4A, as here, we must understand, maybe in these cases, we can remove the tumor with adjuvant and radiotherapy, or we cannot remove because maybe the tumor is unresectable. It means, in this case, is with stage 4B is palliative and symptomatic treatment. List of operations: left lobectomy, removing second and third segments, left hemihepatectomy, removing 1 to 4 segments, right hemihepatectomy, removing of 5 to 8 segments. Extended right hemihepatectomy, removing 4 to 8 segments. Atypical resection, characterization of intrahepatic arteries for chemotherapy, immobilization of intrahepatic arteries, cryoablation, hyperthermic destruction, drainage of bile duct. Surgical excision, you see. According to some authors, combination of liver transplantation with radio and chemotherapy provides 18% 5 years survival rate. Wait a minute, please, because we have other lecture. pancreatic cancer. Just a minute, please.
Ага, не сохраняем. Так, пока. Так, здесь мы чуть-чуть ее сворачиваем. Вот это, да?
Да, вот это.
А что-то она... Вот это старая была, да?
Да.
Что-то она не закрылась, да?
Но я не закрыл.
Так нет, она должна закрыться. Вот это надо закрыть, да? Старую.
Давайте я сделаю.
Ну вот я закрыл ее, она что-то не закрылась.
Закрылась.
Теперь надо вот эту поставить.
Ага, спасибо. Ну, continue our lectures. Now pancreatic cancer. Risk factors. Consumption of alcoholic beverage, smoking, fatty and spicy foods, diabetes mellitus, cirrhosis of liver. Precancer disease, adenoma of pancreas, chronic pancreatitis, cyst of pancreas. Localization of cancer. No, anatomy of pancreas, if you remember, is head part of pancreas, neck part of pancreas, body, and tail. Pancreas 65.2%, ampulla of Vatir 12.7%, extrahepatic bile duct 11.3%, gallbladder 7.3%, duodenum is 3.5% of patients. No localization of the pancreas. It is here's duodenum. Spleen artery. Here is common bile duct. Here very important things is under the neck of the pancreas, two minor vessels. The mesenteric artery mesenteric superior at vein. And here we see it. Tumor invades the head of pancreas, 50 to 60% of cases. the body 10%, the tire 5 to 8% of cases, complete lesions of the pancreas 20 to 35% of cases. Histological classification: adenocarcinoma, squamous cell carcinoma, cyst adenocarcinoma, acinar cell carcinoma, and undifferentiated carcinoma. Metastasis. Lymphatic metastasis of pancreatic cancer has got 4 stages. The first stage affects the pancreatoduodenal lymph nodes near the head of the pancreas. The second, retrapyloric and hepatoduodenal lymph nodes. The third, the celiac and superior mesenteric lymph nodes. The fourth stage, retroperitoneal para-aortic lymph nodes. Hematogenous metastasis, distant metastasis, to the liver, lungs, kidneys, and bones. Furthermore, there is an implantation of tumor cells via the peritoneum, contact metastasis. Tenem classification. TX is not enough information to assess the primary tumor. T0, the primary tumor is not defined. T in situ, carcinoma in situ. T1, the tumor is within the pancreas. T1A and T1B. T1A, the tumor is less than 2 centimeters in greatest diameter. T1B, the tumor is greater than 2 centimeters in greatest diameter. T2, tumor invades one of the neighboring organs, likely duodenum, bile duct, or the tissue around the pancreas. T3, tumor invades one of the neighboring organs, likely stomach, spleen, colon, closely spaced large vessels. And lymph node status. NX, not enough information to assess the regional lymph nodes. N0, regional lymph nodes are not affected. N1, regional lymph nodes are affected. And M, status M. MX, not enough information to assess distant metastasis. M0, distant metastasis are not detected. And M1, distant metastasis found in other organs. No, and the staging depending on TNM classification. Stage 1, 2, 3, and 4. No, please, you can read T1 in 0 in 0, T2 in 0 in 0, and stage 2, T3 in 0 in 0, T2 in 0 in 0, stage 3, any T in 1 in 0, stage 4, any T, any N, and M1. Clinical features. Mechanical jaundice due to invasion or compression of bile duct. The most common in head of pancreas. Courvoisier's sign or Courvoisier symptom. When we palpable, painless enlarged gallbladder in patient with mechanical jaundice. A pair in case of tumor localization in head of pancreas. Pain in cancer pancreatic head is constant and due to stretching of liver capsule. A pair in right epigastrium. Cancer of the body and tire of the pancreas is accompanied by pain which may radiate to the back due to invasion to solar plexus. Tumor invasion of the stomach and transversus colon leads to their obstruction. There may be bleeding from the affected organs. General symptoms. If you remember, we discussed the symptoms in oncology. There are general symptoms for all localization, and there are specific symptoms for every organ alone. General symptoms: cancer intoxication, anorexia, weight loss, and fatigue. Diagnostics: ultrasound of abdominal organs, CT scan with contrast or MRI, contrast X-ray of stomach, duodenum, feeding defect in case of invasion of these organs. Endoscopic retrograde cholangiopancreatography for assessment of bile ducts and morphological verification. Endoscopic ultrasound, laparoscopy or laparotomy with biopsy. Cancer antigen 19-9, angiography. Compression of stomach, posterior wall of stomach by tumor of head of pancreas. Invasion of stomach wall by pancreatic cancer. Invasion of duodenum wall by cancer of head of pancreas. No normal pancreas. Mass in pancreatic tile. And liver nodes. What pancreatic tile? Liver nodes. X-ray examination of the stomach and duodenum. Percutaneous transhepatic cholangiography. The method is used to identify the level of obstruction. X-ray feature is the presence of full block and circular or semicircular stump with irregular and intestinate contours. Percutaneous transhepatic cholangiography. No, what here we see tumor. Common bile duct, it's common bile duct. Here we see the tumor. Tumor of vertebra ample of vertebra. What here? External drainage of the bile ducts of the left lobe of the liver. Pancreatic cholangiogram. Cancer of the pancreatic head, block of the pancreatic and common bile duct. In this case, the patient will have what? Mechanical jaundice. Yes, because obstruction the common bile duct. Pancreatic cholangiogram, cancer of the pancreatic head, stenosis of the main pancreatic and common bile duct. What? The additional method which helps to put the diagnosis of pancreatic cancer to this tumor marker cancer antigen 19-9. Manifold increasing of this marker in blood indicates the development of cancer of the pancreas. Radio is a top method. With octreoscan, 3 octreotide. Somatostatin analogy with radioactivity is used in the diagnosis of neuroendocrine tumors of the pancreas. Treatment. Method of treatment. The first stage, this it means T2, T1, 2, T2 in 0, is surgical. Second and third stage, surgical with adjuvant chemotherapy with radiotherapy. Stage 3 and 4, palliative or symptomatic surgical treatment. Most common operation in case of pancreatic cancer, Whipple operation, distal resection of pancreas. Distal resection of pancreas if the tumor localized in tail of pancreas. Whipple operation, it means the cancer in head of pancreas, usually with mechanical jaundice, For the first, we must liquidate the mechanical joints, and after we can do big operation, likely Whipple operation, which including part of stomach, duodenum, head of pancreas, and part of common bile duct. Bile drain, if patient had jaundice and the stage is the last stage, we must do palliative operation to liquidate the jaundice. The most common here is by drain, outer drain we put. Chemotherapy, including these preparates. The first, removal solid tumor of the body and tail of the pancreas. Produced Trendelenburg in first pancreatectomy performed Theodor Pileret, 120 years ago. Total pancreatectomy this complex. We must remove it. Pancreatidodenectomy Whipple's operation, as we told, part of stomach, part of pancreas, duodenum, and part of common bile duct. Mean Whipple operation. Plastic endoprothesis in case of carcinoma, ample of Wattier, with jaundice. Prognosis. Prognosis depending on performed of the operation and the stages of the disease. So thank you very much. See you next time. Goodbye.